Thank you very much for kind introduction, Mr. Chairman. Thank you, Claudio, for invitation. It's been kind of a highlight of my career to come here for the last 3-4 years and enjoy and learn more than I can contribute. Thank you very much. So I thought that we can focus on different aspects of biomarkers of acute kidney injury. We have tried over the course of last few years to demonize serum creatinine. I thought that should probably spend a little time on serum creatinine to go over good and bad side of serum creatinine, and then focus on injury biomarkers, in particular new developments on the field. As you know, KDIGO definition is based on two functional biomarkers. One is urine output and the other one is serum creatinine. That increase in serum creatinine along with decrease in urine output defines acute kidney injury at the moment. Obviously, serum creatinine comes from creatine and creatine phosphate hydrolysis, which is a spontaneous process, and creatine phosphate is the most available type of energy. When we want to do a rapid run, the first energy that we get is from metabolism of creatine phosphate. Now, creatinine therefore comes from muscle mass. Therefore, muscle mass can determine amount of creatinine. On the other hand, the molecule of cystatin C comes from all nucleated cells. Although it is impacted by muscle mass, it is also impacted by the whole mass of the body. Therefore, the impact of muscle in serum cystatin C is significantly less than serum creatinine. Now, creatinine obviously has a lot of issues, and if we don't use it correctly, it would be misleading. So first of all, it's a delayed marker, and it depends on the body habitus. So we know that patients, when they have acute illnesses, they have comorbid conditions, different muscle masses, and they come to our ICU or hospital, and they go through several different events, and then they start losing their kidney function. After a day or two, we can see impact of those changes in serum creatinine when we define acute kidney injury. Indeed, if you look into this patient population of acute decompensated heart failure in a hospital, you see that about 60% of patients have rise of more than 0.1 microgram per deciliter of serum creatinine, which may take about 3 days to happen. Those who achieve acute kidney injury definition, 1/3 happens in the first day, 1/3 happens in the second day, and about 1/3 of patients may take 3 days for them to actually reach definition of acute kidney injury. Now, we know that MELD score that is used for a ranking scoring for liver transplantation is heavily influenced by serum creatinine. And if you look into these MELD score examples, as you see in a fourth line, when INR and bilirubin is normal, but serum creatinine is 3, you can reach MELD score of 17. And based on the UNOS data, 15 to 17 MELD score is the time that liver transplantation is a wash. Below 15, transplantation would increase mortality. Above 17, transplantation would decrease mortality. Therefore, creatinine alone can get patients to the border of need for liver transplantation. This is an important factor. However, the problem with creatinine is that over the course of the time that MELD was being used for patient selection for liver transplantation, as you can see, female patients are discriminated against because they have less muscle mass, and we have less and less number of female population receive liver transplant, and obviously their mortality is significantly higher after end-stage liver. And this is true up to the GFR, baseline GFR about 65. Every single GFR at the baseline, based on serum creatinine, is discriminated, the female gender is discriminated against. And this is not only due to shorter, smaller body, it is due to less muscle mass. And also patients, male individuals have some additional exceptions, including hepatocellular carcinoma, which don't follow the MELD score. Now, there are good signs in serum creatinine as well. Obviously, it is very available, and it is complementary to other markers that we use. We know that serum creatinine may have less value when it comes to exact determination of differential diagnosis or other causes of acute kidney injury, but it is very available to a point that even in third world, you can use the point of care devices to measure creatinine or BUN within saliva and identify patients who have acute kidney injury. And indeed, in Jay Coyner's study, when he was trying to find a model for prediction of acute kidney injury, serum creatinine got the highest importance in the model. Regardless of how he looked at the model building process, serum creatinine was always at the top of value in the model. Also, it can help us to predict outcome. As I mentioned, serum creatinine comes from the muscle. So this tiny guy, in comparison with this muscular guy, they should have different production of serum creatinine. And indeed, the data, as you know, there is a paradox, obesity paradox in ICU, that patients who have BMI of about 40 to 45, they die the least in ICU. And this is used as a surrogate for muscle mass. And indeed, I'm trying to work myself up to BMI of 40, 45 to have less mortality in the future ICU admission. So we looked into about 12,000 patients at Mayo Clinic, and we found the serum creatinine actually can predict mortality and length of ICU stay in a U-shaped form. So very low, very high creatinine would increase mortality or length of stay in ICU. This is a very large-scale study in Australia and New Zealand. About 1.5 million patients screened. About 1 million patients were enrolled. After those excluded with no data and other exclusion criteria. And again, that U-shaped form was observed. Patients who have very low creatinine versus those who have very high creatinine, they have higher mortality. This is among 1 million patients. Among 100,000 patients who had height and weight available, that U-shape even was more obvious. Those with lower serum creatinine had higher mortality in comparison with those with higher creatinine after adjustment for weight and height. Then we looked into Mayo Hospital, which we have a hospital, about 2,000 bed hospital. We looked into all patients were admitted over the course of a few years. About 74,000 patients were enrolled. We looked into their mortality rate. This is a raw mortality rate. As you can see, those who have very low serum creatinine and those who have very high serum creatinine, they have highest mortality. And then we adjusted based on all factors that could potentially impact serum creatinine. Age, sex, race, BMI, all the comorbid factors, Charleston score, coronary artery disease, CHF, even for and paraplegia. And as you can see, odds ratio of mortality of those who had serum creatinine of less than 0.4 microgram per deciliter was the highest in comparison with those who actually had very high serum creatinine. So creatinine could be used to help us identify higher risk patients. This is among another obesity paradox among dialysis patients this time. So patients on dialysis, if they are obese, they survive longer. And indeed, when the investigators looked into serum creatinine of patients who have been on a stable dose of dialysis, 3 times a week, stable dose of dialysis, those who had the higher creatinine after that stated dose, they had the lowest mortality, and those who had very low creatinine after dialysis on a steady dose, they had higher mortality. Then they followed them for 3 to 6 months. Those who gained creatinine over the course of time means that they gained muscle. They had lower mortality. Those who lost muscle, therefore their creatinine decreased over the course of 3 to 6 months of a stable dose of dialysis, they actually had the highest mortality. So muscle mass based on serum creatinine could help us to identify patients that are sicker. Now, this was the functional side of kidney biomarker. Now, a little focus on injury biomarkers. This is the landscape of biomarkers at the moment. The gray boxes, this paper was published right before we published our paper for cell cycle arrest biomarkers, so I added them at the bottom of this particular figure. So we use them for all the biomarkers for differential diagnosis, early detection, prognosis, And for current state, we have several different tools. We use urine indexes to identify prerenal state versus ATN. We don't do biopsy. We should probably do more biopsy of patients with acute kidney injury. Urine microscopy is very specific, may not be as sensitive. Functional measured by GFR, as Professor Shaw yesterday mentioned, would become potentially available to us, or serum creatinine. Creatinine clearance has been tested. Biopsy, again, for early detection is a possibility, and definition of acute kidney injury and urine microscopy could be used for prognosis. The landscape for newer biomarkers of functional injury biomarkers also, as you can see, is outlined in this figure. Why it is important to have injury biomarkers? Usually traditional biomarkers identify patients in 2 to 3 days. As I mentioned earlier, for serum creatinine, it's, sometimes about a third of patients with heart failure, they develop acute kidney injury 3 days after admission, and traditional markers therefore are late. When kidney injury happens and kidney function declines, mortality increases, and our therapeutic window starts to narrow. And therefore, finding biomarkers that identifies these patients at the time that we can actually do something to reverse the course, it is extremely important. Now, a good biomarker should be inexpensive, accurate, easy to measure, a point of care. You can't expect the test that the results come back next day to be useful in decision-making process. It should be sensitive to the intensity of injury and also sensitive to the therapy and recovery of the acute kidney injury. Just a few examples. This is a post-cardiovascular surgery cohort. As you can see, acute kidney injury was defined when serum creatinine increased by 100% or patient needed dialysis. And they use IL-18, urinary IL-18 in this case, a quantile of IL-18. The highest quantile had 12 times higher chance of developing acute kidney injury. When acute kidney injury was diagnosed, about 24 hours before IL-18 showed signal that these patients may have acute kidney injury. Same for urinary NGAL. As you can see, odds ratio for development of acute kidney injury in fifth pentile is about 5 times. Now, it is important to be able to merge the functional and the injury biomarkers together. These are complementary. These are not against each other. Having injury biomarkers doesn't mean that we don't need functional biomarkers. The reason is outlined in this figure. As you can see, those who have no increase in creatinine or other functional biomarkers, no injury biomarkers, and have no acute kidney injury. Obviously, those who have both of them elevated, they have true acute kidney injury. But there are a group of patients that they have no increase in serum creatinine, but they have injury biomarkers. And those who have increasing creatinine, but no sign of injury when injury biomarkers are measured. These are kind of, we used to call them prerenal state. Now, this is Tribachi's cohort. It's a large cohort of patients. They collected biomarkers among them. Just focus on these particular two urinary NGAL2 group, those who had no acute kidney injury, those who had acute kidney injury, based on a tertile of biomarker level. As you can see in this particular figure, those who had no acute kidney injury but had elevated injury biomarker had the same mortality as those who had acute kidney injury but no elevation in biomarkers. Indeed, you can make an argument that subclinical acute kidney injury or prerenal state could have the same chance for a higher mortality, particularly in this cohort. Now, this is a systematic and a review of literature in 2012 before new biomarkers came out. And the authors went to say that promising results with the new biomarkers for early detection and differential diagnosis of acute kidney injury in clinical practice can only be confirmed in the setting of children without comorbid condition. The reason was that NGAL and other biomarkers was tested after cardiovascular surgery in pediatric patients who did not have a chance to have atherosclerosis due to hypertension or diabetes. They had pristine vasculature, that pristine other organs, single organ failure with the cardiac surgery. However, they say that results are far less robust when we search for validation in adult heterogenic population, particularly those with comorbid conditions. At that time, under leadership of Professor Kellum and Professor Ranko, we decided to kind of approach this in a different way. We decided to look into patients who had no acute kidney injury, but they have a very high risk of development of acute kidney injury. We collected blood and urine samples among the 500 of these patients in discovery cohort. We went to literature, found 340 protein names that could potentially be associated with acute kidney injury. Then we tested these proteins among these samples, in blood and urine samples. It turned out that 2 of these proteins stood out in urine samples, stood out as prediction of acute kidney injury before urine output goes down or serum creatinine increased. In follow-up validation study of about 720 patients in multi-center study, we validated these biomarkers and identified these 2 proteins as tissue inhibitor metalloproteinases 2 and insulin growth factor binding protein 7. And the reason that we chose to use the product of these 2 proteins was this picture. As you can see, Team 2 did slightly better in sepsis group, and IGF-BP7 did slightly better in surgical group. So we thought that we can get all comers if we use the product, which is known currently as NephroCheck. Now, what these proteins do for kidney, we know that when cells are damaged, they go through cell cycle. In G1, they gather nutrients. In synthesis, they double their chromatin. In G2, they prepare for mitosis, and then finally mitosis. Through this course, at least 3 major checkpoints, cells stop and review their own DNA content. And the role of these 2 proteins is to halt the progression from G1 to S, to allow cells to review their DNA content, assure that the cells are ready for duplication. This was further validated in an North American group of 400 patients, and they found exactly similar results as we found in Sapphire trial with area under care of 0.82. The idea was that they add value to clinical decision making. So we made a clinical model with area under care of 0.7. When we added biomarkers to this clinical model, it added significant value. So area under care went up to 0.86. They can predict a longer outcome. For clinical approach, how we can use them, we know that the late management of acute kidney injury mainly is pray and just wait. Using these biomarkers, we can identify patients that are based on KDIGO guideline that are a high risk group. We can provide further support in the right time. Instead of being really reactive to creatinine to go up to stage 3 and start patients on dialysis, we can remain proactive using these biomarkers in a way that if your patient has low risk, you don't really need to do anything apart from monitoring. In very high risk patients, call nephrology to start dialysis early. In equipoise group, biomarkers can identify very low risk to very high risk or average risk patients. Professor Ranko led this NephroCheck rapid response team, which he will describe in next talk. And we thought that using this particular approach, we can get engaged a lot earlier, avoid further progression of acute kidney injury, and probably save lives. Take-home points: functional biomarkers have limitations and strength. Injury and functional markers should be used as complementary tools, and panel biomarkers may help with differential diagnosis. With that, I thank you for your attention.